But what about other means? The ECG is great, and I think you can understand that ECG is a really powerful tool if it's handled by trained individuals. But it is only showing us about the cycle. It's not telling us about volumes, it's not telling us about stroke volumes and so on. And yet actually, particularly in exercise science, those are a couple of things we really need to understand. We want to know about the cardiac output. We want to know about the stroke volume, because if we think about our basic systems physiology, VO2 is Q times AVO2D. And we know that Q is a function of heart rate and stroke volume. So although that the ECG gives us some idea about the kind of the pathology of the heart, it doesn't give us all the information about the functioning of the heart. Now, there are a number of different ways that can be undertaken to assess this using things like echocardiograms as opposed to electrocardiograms. We can use Doppler. We can even use what's called a CO2 rebreathing technique, but these are all actually relatively invasive techniques. A non-invasive technique that has been around now for a number of years, originally developed by NASA, but didn't really become commercially available to use within the field of exercise science until about 6 years ago, is what's called thoracic impedance cardiography. Its brand name is PhysioFlow. So what's the rationale for this? Why would we want to use thoracic impedance cardiography? Well, if we think about it, if we want to assess, or the assessment of cardiac output during exercise is important for both research and in clinical settings. If you think about the gold standard measurement of Q, which is the direct thick test, which is literally taking it across the aorta, think about how invasive that is, or using something like pulmonary thermodilution methods, you'd have to catheterize somebody, you have to catheterize the pulmonary artery. That's incredibly invasive, it's incredibly painful. So we need techniques which are less intrusive. We also need techniques which can be used in exercise. It's very difficult to do that kind of approach in an exercise condition. It has been done. People like Jose Calbert, working with Ben Saltine, did do that in exercise. And they have people actually going to VO2 max, but it's incredibly difficult to be able to do. You need trained physicians and so on. Well, one of the things we know, we've seen it with our ECG, is that changes in electrical impedance during the cardiac cycle, so we know there are electrical activities, but now we're getting to impedance, provides an automated and continuous measurement which is non-invasive and simple to use. Well, what do you mean by impedance? Well, impedance really refers to, if we understand the amount of an electrical, this is in very simple terms, but the amount of an electrical signal that's being passed into the heart and the amount of that electrical signal that comes back from the heart, well, where's it gone? Well, it's been absorbed. And we understand that there is an absorbency of electrical signal, of refraction, I should say, of electrical signal in relation to fluid. And so if you know how much is being passed across the heart and how much is being reflected back, you can use that, and this is in very simple terms, you can use that understanding of that changing in the electrical signal, which is not the same as the ECG. The ECG is just monitoring the signal, whereas what this is doing is it's really measuring the way in which the electrical signal increases and decreases across the heart. You can use that to indicate the change in fluid movement across the heart. In other words, blood flow. So here you've got the ECG trace. What the PhysioFlow does is it records these two additional signals, which you can see on the right-hand panel. So these are the impedance traces, which is delta Z, which is the change in Z, and then what's called its first derivative, which is delta Z, delta time. And what these show us is the ECG gives us the electrical activity, fine, but what these give us is how that fluid is being moved through the heart. And it's very much along the same principles if you use, for example, bioelectrical impedance for recording, say, body fat. Bioelectrical impedance for body fat is based upon a known signal being passed across the surface, and the difference between the known signals being passed across and the amount that's being refracted back. And the difference between the two is the amount that's being absorbed. This works on very, very similar principles. And we know about the absorbency of the signal in relation to fluid. And so if we know the rate at which the heart is beating, which we get from the ECG trace, and we know for every beat of the heart, the way we get the degree to which we get the change in the impedance signal, we can start to make calculations and really quite profound inferences about the cardiac output of the heart. And the way we do that is we actually just use 6 electrodes. They're not all shown on here because I'll explain in a moment, but you can see we have the 2 which are sitting on our carotid. So you can see those at the top, which is Z1, Z2. You've then got what's called EKG1, so that's ECG1. Remember I said Americans write it slightly differently. Then you've got EKG3, you can see EKG2, you can see Z3 and Z4. And we've also then got, so you've got 1, 2, 3, 4, 5, 6, there's your 6 electrodes. And what they do, again, a bit like you got with your ECG, they give you kind of a representation of the heart. The EKG ones are there just to get the electrical signal for the ECG. Then the Z ones, the Z1, Z2, and Z3 are used to derive the delta Z and the delta Z, delta D, delta Z, delta T timelines. In other words, the change in the movement of the fluid over time. And from those we're able to derive our cardiac output and therefore our stroke volume, the volume of blood pumped per beat of the heart. Very different to what you're getting with your ECG. How good is it? Well, there's a number of studies that have been performed where this has been compared. Now this is really important because this is where it's been compared to the direct Fick method. Now the direct Fick method is referred to as being kind of the gold standard method. Remember that it's really invasive. It's catheterization of the pulmonary artery. You're recording across the pulmonary artery the flow of blood. Therefore, you're getting a pretty accurate measurement of what is going on per beat of the heart. And here what they've done is they've just done a simple correlation between the two, and you can see that the direct Fick is on the x-axis, and you can see the physio flow is on the y-axis. And you can see that at rest, there's very, very good agreement. The agreement becomes less strong as we go into exercise, but exercise, as we know, drives quite a lot of variables and variances into data. But again, you can still see there's a fairly tight linear relationship between the two, indicating that physio flow, or in this case thoracic impedance cardiography, gives us a really good indication of the cardiac output and stroke volume of the heart. But we have to still learn the lessons from the ECG, which is, unless we've got adequate training in the placement of the electrodes, this does not work. The other thing that you have to take into account with this is you need to know blood pressure, because blood pressure is fundamental to things like the pumping capacity of the heart, because we've got to take into account systolic and diastolic pressures in the heart and the venous return. And unless you get an accurate recording of blood pressure with the participant in the position to which they're going to perform the exercise, so for example if they're doing cycling, you need them sat on the ergometer in that position. If they're doing running, you need them standing up. If they're doing rowing, you need them sat in that position. Because we've got to reflect the role that gravity is going to play on that blood pressure. The blood pressure is fundamental to that signal and to that noise. The other thing we have to do is we have to reduce the noise artifact in our electrodes when we're exercising. Remember, electrodes will move as we start to exercise, so we either take them down, or one of the things that we tend to do here is we actually put a tubic grip over the chest region to keep them quite tight so that we get less noise artifact in those electrodes. And what does the data tend to look like? Well, this is data from a study that we published fairly recently where we were comparing an oral contraceptive group to a non-oral contraceptive group of female athletes. And what you can see is you can see the cardiac output responses, which is panels A and B, and then you can see the stroke volume responses, which is panels C and D, for the different phases of the menstrual cycle, both for oral contraceptive and for non-oral contraceptive groups. It doesn't matter which is which group, but what it shows you is what we referred to in the previous session in podcast 1, which is generally you see a linear-like response for cardiac output against exercise intensity, in this case percentage of VO2 max. And we see on the whole in this group a levelling out of stroke volume at around about 60% VO2 max, despite the fact exercise intensity continues to increase, but using this non-invasive technique. So this is a very useful tool, and in fact it was developed, as I say, for NASA because they wanted some way of identifying fitness changes in their astronauts. But it's also used by surgeons as well as exercise physiologists, because surgeons is where it was originally developed. Surgeons wanted to be able to non-invasively, very quickly monitor cardiac outputs within their patients to see how the heart was functioning on top of the ECG. The ECG is telling us what should be happening, but this gives us actually the volumes that are being ejected per beat of the heart.